Good morning, ladies and gentlemen. And thank you, Anusha, for your wonderful introduction. First of all, I would like to also thank the organizers of this conference for putting together this wonderful event for us. And also, I'd like to congratulate all of you for coming to this event, where we will hopefully be able to share our ideas and focus our attention and improve our learning and our abilities. And I'd also like to, as keynote speaker, express my gratitude for this honor and for the opportunity to share with you what is in fact a career-long effort to provide, initially focused on providing safety for the marathon. But then in thinking about this presentation, I'm going to supersede that by presenting this topic at the top, that aspirin, low-dose aspirin, guided by coronary artery calcium scoring for improved prevention, belongs really in all of medical practice. So I started off, as the topic of my presentation was related, about enhancing marathon safety and the role. I've been an advocate for the role of low-dose aspirin in cardiac arrest prevention. But I want to now expand that on a whole new level to make the case that low-dose aspirin belongs in medical practice on the level of primary care. And the three takeaway concepts that hook this up are shown here. The first is to describe how the use of coronary artery calcium scoring independently stratifies the risk for major acute cardiac events, including sudden cardiac death, for in even young individuals. And the second point is to realize and describe that there are two randomized controlled primary prevention trials that demonstrate that low-dose aspirin is cardioprotective. And third, that to realize that the American Heart Association and the American College of Cardiology guidelines, the current guidelines that have been in place since 2019, do call for the use of low-dose aspirin in high-risk individuals. So improved risk stratification depends upon improved stratification. For example, it circles back to the first point about coronary artery calcium scoring. So this is a picture of me with my a number from an early 1970s Boston Marathon, where I ran the race roughly in the 1970s and 80s, then matriculated to the medical tent for the next several decades, but had the opportunity to study a group of physician runners for that whole time period. So this is the Boston Marathon. This is the, some people call it the crown jewel of the sport, but because of, especially we're in London, we would include the London Marathon in that, even though the crown jewels apparently are not, you can't see them at this time because of all that's going on around the Tower of London. But this is the event that people that are interested in the sport regard the marathon really as the epitome of what everything that we know about the cardioprotective benefits of exercise. And this line drawing of Murray Middleman's has stood the test of time from 1993, and it compares the relative risk of myocardial infarction onset to the habitual frequency of vigorous exercise, and shows that from the right-hand side, the tallest bar, people that are inactive, to people that are moderately active, more active, and so on, that the risk of an acute MI onset goes down, 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 20-mile weeks in marathon terms to 40-mile weeks to 60 and 80-mile weeks. But that dotted line, there's the rub. to quote Shakespeare's Hamlet, which, by the way, is on in London right now at the London Theatre, Hamlet. That dotted line shows the resting risk of cardiac arrest and sudden death. And compared to the resting risk, the risk goes down, down, down the more you exercise, but it's still, on the far right, there's a gap. So that gap represents the transiently increased risk for a cardiac arrest during the race. And that's a consensus of all sports cardiologists. So I'm not only interested now in this talk in that delta, that dotted line to the transient risk of cardiac arrest during the race, but look over on the right side and think about the 800,000 deaths from coronary artery disease that will occur in the US this year. And 40% of those are sudden cardiac deaths that will occur in people who have never been diagnosed, who are previously asymptomatic. And what I want to do is apply the strategy that I was initially proposing in marathon runners to practice at large. So if this, of course, is a drawing of Pheidippides arriving in Athens from the plains of Marathon, arriving and announcing the victory over the Persians and then collapsing and dying. And this is the index paper on cardiac arrest during long distance running that describes Aaron Bagish, a colleague of mine, being the senior author. It's the RACER study. It's the race-associated risk of cardiac arrest, a registry from 2000 to 2009. And he interpreted this paper as meaning good news for marathon runners because the absolute risk of cardiac arrest was so low. However, if you read the fine print of the article, and it's even in the abstract, male gender and the marathon were independent risk factors for cardiac arrest. And we're fortunate at this time for this talk to now have the follow-up of this study, the second RACER study, which covers the time period from 2010 to 2023. And that showed that the risk of cardiac arrest right up until the present time is still the same as it was at the turn of the century. And that most of the fatalities were in middle-aged men with underlying coronary artery disease. The good news for the second RACER study is, however, that fatalities were decreased. And this was done by race directors embedding proficient cardiopulmonary resuscitation into the race course, especially near the finish line. And when a runner has a cardiac arrest, if they can be defibrillated with an AED before the ventricular fibrillation degrades into a straight line, that the runners might be saved. But the real challenge is to the safer studies from South Africa point out, because of the continued life-threatening events in races in South Africa, both the Comrades Marathon and the Two Oceans Marathon, the real need is to have an evidence-based approach to prevent the cardiac arrest from occurring in the first place. So this is a slide of me in my first try at a marathon in Newport in 1972, and the handwritten numbers. And I made the rookie mistake of grabbing what I thought was Vaseline, but it was Fostex out of the medicine chest, which you're supposed to put in friction points. And I started having suds coming out of my shorts midway through the race. But I couldn't get a number because of slow time, but there's a picture of me in a race with wearing a singlet from the American Medical Athletic Association, a group of roughly 200 doctors come together every year in Boston, have a medical meeting about the marathon, and run the race with official numbers with a more for giving a qualifying time. So I had a chance actually to then start to study those runners in races. And this is an idealized representation of those runners. They're middle-aged male physicians who run marathons. And many of them were in the physician's health study, which I'm going to point out in a minute. The final report on aspirin in the physician's health study showed a 40% decrease in first acute heart attacks in these healthy middle-aged men. That's a finding that still is valid and has never been challenged. So the first studies that we did was looking at creatine kinase elevation in marathon runners, relationship to training and competition. And this was from the Yale Journal of Biology and Medicine in 1980. And it showed that there's a tremendous increase in creatine kinase from 160, basically normal, to 3,500 after the race. No secret, if you've ever run a marathon, your muscle is forced to work after it's run out of glycogen, and you get acute muscle injury. So I asked Bob Lopez, who was head of the Brigham Lab at the time, to run CKMBs on this. CKMB had just come out as a qualitative test for an acute MI. And lo and behold, most of the tests were positive, including my own. So this set us off on a search for the explanation. And we actually did a muscle biopsy study in marathon runners, which showed a balance of injury and repair with a persistent presence of regenerating fibers, which are characteristic of muscle injury and presumably have the CKMB in it. But then we also then found out when troponins became available, we tested troponins, and troponins were also elevated in some runners, even in a level that is characteristic of an MI. So let's try to think about this slide, which shows the rare event of a sudden cardiac arrest, sudden death in a marathon runner. The healthy runners around him cross the finish line with inflammatory biomarkers. That it's the same inflammatory storm, the same cytokine storm that occurs in runners with acute MIs. Elevated IL-6, 100-fold elevations, then CRP elevations the next day, studies that we did with two post-race biomarkers. And then also looking at hemostatic imbalance, and found that there's a prothrombotic effect that occurs in the runners, and even activation of platelets. There's a cardiologist who collaborated with at Mass General, Melissa Wood, who did echocardiograms on runners showing that there's a transient right heart dysfunction that occurs in runners, and we showed platelet activation in those same runners. So it's hard not to connect the findings of RACER 2, that most of the cardiac arrests were occurring in middle-aged male marathon runners, with the findings of those studies. So around the same time as the first RACER study, I had an article in the Green Journal, Phidippides Redux Reducing the Risk of Cardiac Events, looking for a way to make the sport safer. And then by this European Heart Journal, proposed aspirin and as a way to attenuate this risk. But importantly, guided by coronary artery calcium scores, a value of 100 Angston units is roughly the value that is a cutoff above which there's an 80% higher risk of an major acute cardiac event compared to folks with lower risk. So aspirin use can be guided by coronary artery calcium scoring. So to me, it's as simple as a 1, 2, 3. If running a marathon transiently increases the risk for cardiac arrest in middle-aged, especially middle-aged men with subclinical coronary disease, and low-dose aspirin use significantly reduces first heart attacks in middle-aged men, it's a no-brainer that coronary artery calcium scoring stratifies that potential benefit of aspirin. So here's a colleague of mine, a physician who's almost my age, who's been the head of the MGH marathon team for many, many years, decades, wonder what his coronary artery calcium score is. I've sort of written to him and don't have a response for you on that. But imagine him on aspirin versus not on aspirin. And if chest pain or a coronary artery intermediate syndrome were to occur, he would have on board the only drug that's approved by the American Heart Association for pre-hospital use in case of an acute coronary syndrome. And actually, there's a paper by Paul Thompson, who's part of the RACER-1 study, that's a report of 2 runners who experienced chest pain and myocardial infarction after marathons, who had coronary catheterizations at Tufts, survived, but had a proven plaque rupture at that time. And of course, I just want to give a shout out to Dave McGilvery, who's been the head of the Boston Marathon, run the marathon 50 times, runs the race after it's over. And he himself has been very public about missing it 1 year, which was a year when he had triple bypass surgery. So what I'm proposing actually is a connection between the muscle injury and the inflammation. This is standard sort of Jupiter study information that inflammation is the driver of atherosclerosis. Back to the first study in 1899 of marathon runners in a Philadelphia Medical Journal that hypothesized that violent and prolonged muscular exercise could have an adverse effect upon the heart. So we're not talking about myocardial, there is transient myocardial dysfunction, about that being clinically significant, but this being a coronary issue, and that the inflammation causes a systemic reaction that puts otherwise stable coronary plaques, renders them vulnerable. So this is not over. This is, but the times they are changing. I've had to throw in a Bob Dylan here because it's now been found out in the last recent decade, largely from the Netherlands, from investigators in the Netherlands, that endurance exercise promotes coronary calcium deposition. Probably, I think, an explanation could be the repetitive injury to vascular endothelium that over time causes increased calcium deposition. So we have a whole new ball game. And that made me think this is a New Yorker cover 1 year from the New York City Marathon, where in fact there were 3 cardiac arrests in that same race. The London Marathon, by the way, has been almost very severely affected by this kind of event. But it's not just about marathons, because there's very clear, good evidence that in fact, older individuals over 60 have an increased risk of cardiac arrest during recreational exercise. So not just marathon runners, but older recreational exercising individuals would also benefit as well from this same strategy. But here's where I started to pivot offline, so to speak. We've got the benefit of low-dose aspirin for primary prevention of major cardiac events. Besides endurance exercise, which can promote coronary calcium deposition, there are other conditions that do the same thing. For example, periodontal disease, rheumatoid arthritis, and HIV, which promotes, through chronic inflammation, promotes the progression of coronary disease. So all of those types of patients, and that includes, by the way, patients with severe mental illness. My day job is in a psychiatric hospital where I do internal medicine consultations. And patients with schizophrenia have a roughly 10-year reduced life expectancy due to coronary disease. And also, they have a 5 to 7 times higher risk of sudden cardiac death. So I'm working with the psychiatrists who handle the psychotic service in my practice to take this into account and to start to consider doing coronary artery calcium scores on all patients with schizophrenia to find out those who are at risk and therefore give them the opportunity to be protected with low-dose aspirin. So Occam's razor, I'm going to skip this slide, but it really refers to, for those people who have a negative view of aspirin or just can't quite reframe it for themselves, there's another cause of sudden fatalities in marathon runners. It occurs in young women, especially charity runners, which is the sudden onset of hyponatremia, which is actually a form of water intoxication, which other studies on that problem have shown is also due to inflammation, which causes dysregulation of arginine vasopressin, which is the hormone that governs water balance in the body. And that's a factor as well as overdrinking. So both of the causes, hyponatremia, mostly in young women, the cardiac arrest in men are related to this, the rhabdomyolysis and the inflammation. So here's one of us, let's say, confronting a patient and it says, I'm afraid we've had a paradigm shift. So this basically brings up what kind of advice should we be giving to patients? For obviously, we want to encourage patients to exercise, but the real question is what exercise and how much? And there are valued specialists in marathon medicine, like Erin Bagish, who I mentioned earlier, who still feel that the net benefit of marathon running is so great and the risk of the cardiac arrest is so small that he feels that promoting marathon running to middle-aged men is a responsible, heart-healthy approach. But I would add to that for sure, what about the calcium score? One needs to know that, to know who's at risk. So this slide, I just found is just a perfect slide. If you were, imagine being a primary care physician around the turn of the 20th century in Appalachia. And this shows coal miners going into the coal mines, and they were at risk for sudden cardiac death from carbon monoxide poisoning. And below there, you can see there are some cages with some canaries, and those are the canaries in the coal mine. So the canaries are extremely sensitive to carbon monoxide poisoning. And when they got sick, the miners would know there's a danger and they would get out and or even had a system of putting oxygen into the canary to help them not die. So in my view, the coronary artery calcium score is just like the canary in the coal mine for us. And when you're seeing a patient like that previous patient who has the paradigm shift, shouldn't we be talking to them about having a coronary artery calcium score, just like we talk to men, middle-aged men, about regarding prostate problems, regarding a PSA? So back to the 3 points that I started off at the beginning, that coronary artery calcium score is very reliable. And in the guidelines of my own practice, they're called primary care guidelines that discuss coronary artery calcium scoring. The last entry says something like, it's a test that's probably not indicated for asymptomatic individuals. Well, in my view, that's not correct. And that's in fact all wrong. And then describing the randomized controlled primary prevention trials, there are 2 randomized prevention trials, the Physicians' Health Study, which I mentioned already, in healthy men. And now we have the TIPS 3 trial, which describes the benefit of over 30% of adding aspirin to the polypill in preventing acute cardiac events. So we have 2 randomized trials, the ideal type of trial for a cardiologist to endorse something. What they would like to see is specifically an aspirin, a low-dose aspirin trial specifically in runners. But that's not feasible because of the very low incidence of those events. And then down at the bottom, we already have guidelines that endorse low-dose aspirin use in high-risk patients. So we just have to take the information that we now have about coronary artery calcium scoring and circle back, because that is the test that we can use to figure out who is at risk and who deserves to have that low-dose aspirin treatment. The guidelines of the U.S. Preventive Service Task Force don't include the option of using low-dose aspirin, and say that for people, correctly say that for people of average risk, there's an uncertain benefit and a known downside that make it undesirable. But now we have a way to know who's at high risk and who would qualify for the benefit of it. So this is a slide that I made for my 50th medical school reunion, sort of on the burnout issue, and shows that same dummy of me with an old number. And it could be the slide for a talk on when should an aging doctor call it quits. But I haven't done it yet because, in fact, I find myself in the position, if I can beam him up, of Daniel Ellsberg, being regarded by some as a detractor of marathons. But in fact, my goal is to make the marathon safer, and we have a way, I think, to do that and enhance the longevity of the event by making it safer. So here's a slide that shows a bunny on the desk couch getting some psychotherapy. It goes back to being pulled out of the hat. So this has been a wonderful therapy session for me, but I've now got a little grandiose, and I'm thinking about not only saving the lives of a handful of marathon runners, but what about those 400,000 people that are going to die this year, sudden cardiac death with undiagnosed coronary disease? By the way, that includes for me, not only colleagues, but a classmate from my medical school and even a mentor. If they know about their risk, what would they be able to take that into account? And would they behave differently? Those two individuals died on treadmills at home. So I do admit that I've been sort of pulled down off the primrose path and maybe down the low-dose aspirin rabbit hole. But I'm going to close with a philosophical point. On the bottom is a drawing of Ingmar Bergman from The Seventh Seal, which is the dance of death, with the Grim Reaper on the far right. Now, we all know we're going to wind up there, and our patients too, and that's an inevitability. But the top is a dance, not of the acceptance of life, in this case by Federico Fellini in one of his great movies. So the point is to, obviously, for our patients and for ourselves, to be up in that top bracket, celebrating the acceptance of life. And in my view, low-dose aspirin, guided by coronary artery calcium scores, has a role to play in helping us do that. So thank you very much for your patience. I appreciate it.